So who are our discussants tonight?
Zach, do you want to unmute yourself?
Yeah, I'm Zach Stello. I'm a PGY2 at UAB.
Hey, Zach, nice to meet you. Jolt off. PGY, too frightening to say out loud.
And then if anyone else is interested in being a discussant, or we can let Zach struggle alone because he is interested in nephrology. So up to you guys.
I'm used to struggling alone, so it's totally fine.
I wish I had the details of the patient. I remember most of it, but
And Zach, this is like Liverpool. Nobody walks alone. We're all with you, okay?
Yeah. Okay, this was a man probably in his 70s who comes in because of, I believe, lower abdominal pain. He has a history of heart failure, and I don't remember what his ejection fraction was, and no history of kidney disease in the past. When they get his labs, they notice a creatinine of approximately 2.1, and all previous creatinines had been in the low ones, if I remember right. And so that's probably a good way, while we're waiting for Sal to get on, just to talk about what do. You have a guy, all you have is abdominal pain and an elevated creatinine, and on physical exam, he has a benign abdomen.
Can everyone see the screen okay?
Beautiful.
Yeah, it looks great.
I mean, just going off the chief complaint by itself, I'd want to know more about the abdominal pain in general. So I'd get into things like onset. I'd ask him to localize a little bit better, give me some time on the duration, things like that.
Yeah, it's gotten worse over the last few days, and he says he's not making much urine and slower abdominal pain. And it was hard to tell whether he wasn't making urine because he wasn't drinking very much, but I think he wasn't, and he was a little bit nauseous. I'm making this up as I'm going along because I'm trying to remember this. I saw this patient several months ago.
Hey, Zach, 70-year-old men that can't pee, you got to lean into the prostate.
Always. Yeah, especially with lower abdominal pain, bladder distension can certainly cause it, things like that.
So in the ER, they go ahead and do a bladder scan, and he has 500 cc's estimated in his bladder. So it sounds like we figured it out and we don't have to go anywhere, but it's going to get more complicated. If
Dr. Center, you promised us a humdinger, and we got it in the first sentence.
Well, that's what we thought also. Have you heard from Sal at all, Natasha?
I have not. Oh, there he is.
Hey, everybody. Sorry about that.
Hey, Sal, I went ahead and gave them, correct any mistakes I made here, but if I remember right, this guy came to the ER, I think he's in his 70s, or is he in his 80s?
You're right on the money. 79 years old.
Yeah.
Ooh.
And he wasn't making much urine. He had some lower abdominal pain. They did a bladder scan and they found 500 cc's. His creatinine, I thought it was like 2.1 when he came in.
So the numbers that I have are a baseline of around 2, and he came down a little bit elevated at 2.4.
Okay. See, I was making things up, Joel. I really didn't know what I was talking about.
That's what I expect from you.
Yeah, I just make things up. I do that on rounds also.
I never let the truth get in the way of a really good case history.
And I mentioned he had heart failure. Did we have an ejection fraction on him?
Yes, he was mid-range, I believe 40 to 45%.
Okay, so you continue with the story because it gets a little bit more interesting.
Absolutely. So this is a 79-year-old. He has heart failure with mid-range ejection fraction, has some CKD, as we mentioned, with a baseline creatinine around 2, coming in with some lower abdominal pain, some urinary symptoms, some dribbling, some hesitancy, and also with falls. It sounds like falls have been a chronic issue for him, and he states that sometimes when he stands up, he gets dizzy, which he thinks might be related to his falls. It's kind of the main reasons that he's coming in. And then I can kind of stop there or whatever you'd like in terms of medical history, medicines. I think the story and the creatinine are a decent place to start.
Don't be shy, Zach.
Yeah. So when, standing up, then getting dizzy and falling, that points a lot toward orthostasis. And coupling that with somebody who's having trouble making urine or urinating despite appears to be making urine, there's definitely a neuropathy that I'm worried about, some sort of dysautonomia or things like that.
The one disease I never want to miss is a normal pressure hydrocephalus. And I hear somebody who's got some urinary symptoms, and I hear about somebody who's got some gait problems or falls. It's just, you can't sleep on any of those reversible causes of dementia. So just putting that out there. Doesn't fit with the kidney failure, doesn't help with the abdominal pain, but just.
So, Zach, what do you want to do?
I mean, I'd want more information from the guy. Just talking. I mean, yeah, Dr. Toff was mentioning, worry about MPH. So I'd ask about his mental status. If he has any, if there's been like a progressive dementia type thing or something like that. If there's any family around to corroborate it, something like that.
Yeah, absolutely. So his sister provides some collateral information, is most concerned about his recurrent falls. And when asked about confusion, she says, maybe he's kind of not as with it as before, although when kind of talking to the patient, he's able to answer most questions, and sister acknowledges that he doesn't seem that confused right now. That's the history regarding confusion. If you'd like, I can go kind of round out. I can either answer questions about the review systems, or I can round out past medical history, medicines, things like that.
Can we learn a little bit more about prostatic history? Is this a gentleman who has a history of prostatism?
There's no history of BPH when you talk to him or look at the previous PCP notes.
And do you ask? Let's ask him about nocturia, if we haven't already, double voiding, frequency, weak stream, all that stuff. Is that all? Is that kind of directed review systems all clean?
So he does report some symptoms. I did not ask about nocturia, but he does say there is some frequency and weak stream.
Mm-hmm. Any burning when he urinates?
No burning.
How about urinary incontinence or anything like that?
To be honest, I'm not sure if I asked, but he might have reported some symptoms related to that.
And then because of this abdominal pain, nausea, vomiting, diarrhea, constipation, like run through our standard kind of GI abdominal review systems. Any positives there?
So no nausea, vomiting, diarrhea, constipation, is passing gas, and kind of about the lower abdominal pain, does kind of his chief complaint was also the lower abdominal pain, but also it seems that were falls. There's kind of a concern for recurrent falls, which is why he was brought in. So when you ask him on review of systems, he does endorse some like lower abdominal pressure.
Where in the abdomen is the pressure?
Kind of central lower abdominal pain.
And just for clarification, the ER had already established this 500 cc's of retention before we got there. Is that right?
Yes.
And did they put a place of Foley, or did they not? Did they ignore it, or did they intervene?
They placed the Foley. The lower abdominal pain and pressure improved with the Foley catheter placement.
Gotcha. Thank you.
And then his dizziness, do you mind just clarifying? Does he feel like the room is spinning? Does he feel lightheaded?
Sure. When asked multiple times, and as with a lot of patients, might become frustrated when asked the same question multiple times. He does say maybe lightheaded is an accurate description.
Zach,
And
what are you
has he ever-
thinking? I'm sorry, I did not mean to step on you.
No, that's okay. I was just going to ask if he's ever lost consciousness or hit his head from the lightheadedness.
After a fall, he has hit his head. He has had a couple of head CTs that have not shown bleeds. And to his knowledge, he hasn't lost consciousness. He just kind of gets dizzy, lightheaded, falls, has hit his head.
And Joel was worried before about normal pressure hydrocephalus.
Yeah, we're
I believe
clean
the
now.
CT did not show that.
Yep. Yep.
Mhm.
Yeah, that's real helpful.
Well, why don't you give them the rest of the past medical history? There's a question from Josh Morris about what his original CKD was, and that I don't believe that's clear, but let's get his past medical history.
Yeah, good question. So he has hypertension. And as we talked about, heart failure with an EF 40, 45%, CKD. Hypothyroidism. Depression. And kind of related to the possibly related to heart failure, has some ischemic cardiomyopathy, coronary artery disease, and has had stents.
And then I think they need to know the medications because of this lightheadedness.
Absolutely. So medications, atorvastatin 80, calcium carbonate, carvedilol, 12.5 milligrams twice daily, clopidogrel 75 milligrams daily, furosemide 40 milligrams daily, levothyroxine 112 micrograms daily, sertraline 25 milligrams daily.
And
Ours
have there been any changes to these medication doses or anything recently?
Good question. He's sometimes it's hard for him to remember all of his medicines. He gets a little bit of help at home, but he thinks maybe he says his blood pressure medicines might have been adjusted recently. And then for family and social, I'm pulling up right now. But those are his medicines and past medical history.
Sal, I want to get us to the real meat of this.
Mhm.
And since I was the attending, I handed this patient off to Sal. And we thought this was fairly simple. We'll give you his vitals, and we thought we knew what was going on. Adjusting his medications a little bit. Thought that his increased creatinine was just due to the obstruction. But we will find out in another day or two that his creatinine continues to go up. So Sal, why don't you sort of give them the physical exam, because I think you can't get around the physical exam when you get lightheaded and standing.
Yeah. So I'll give physical exam, and then maybe we can talk about what was done on day 1 of hospitalization and the creatinine trend thereafter. Maybe we can do that. So patient's afebrile, heart rate is 61. Respiration's normal. Orthostatic blood pressure was obtained. Lying down was 166/86. And sitting was 131/79. And then respiration is normal and was satting like 98%.
Let me just add to that, Sal. When we tried to stand him up, he was too dizzy to stand up.
And then otherwise, he was in no acute distress. JVP was not visualized. Non-labored breathing on room air. Clear lungs. Heart had a regular rate and rhythm. And then belly was soft. No rashes observed. No lower extremity edema. And from a neurologic exam, there are no focal deficits when thinking about dizziness. So strength was intact, alert and oriented, and then reflexes were symmetric throughout.
Did you guys ever feel like it was safe to walk him and assess his gait or anything?
So as Dr. Center mentioned, I wasn't there when he was first admitted. So my understanding is that he was so dizzy, he was mostly in the bed. Is that right, Dr. Center? When he stood up?
That's correct. And you need to also mention what his pulse did when we did the orthostatics.
Yeah, I think I have that here too. So it seems the numbers that I have here are 60 to 59, but Dr. Center, that might be from later on in the hospital course.
No, that was one of the things that we had to work with, was that his pulse did not increase with his blood pressure dropping and him becoming symptomatic.
That carvedilol might be doing a lot of work here.
So that's exactly the point, the reason that we brought that up. So now we have a guy I'm going to reframe the problem representation here. We have a guy who comes in who has urinary retention of 500 cc's, who is on the medications as listed, who is orthostatic by blood pressure, but not by pulse. So Zach, what do you think of all that?
I mean, yeah, that's certainly abnormal. I mean, to say that CoReg would do all of that, that's pretty significant. I don't know if a beta blocker could solely prevent any sort of change in heart rate with a blood pressure difference that significant. I don't know. That's a lot. But
What's your experience, Joel?
I
You
find
mentioned
that
the
people.
carvedilol.
I did, but I'm with Zach here. I don't think I think that's a heavy lift for beta blocker. Usually, patients that truly need to break through just fine. Unless but we haven't seen the electrolytes, and there may be another cause for the bradycardia that we have, or relative bradycardia that you guys are holding back on. I am certainly wondering with his profound orthostasis, not so profound, but the fact that he can't even stand or even sit up without getting dizzy makes me wonder, adrenal insufficiency is kind of bouncing in my head. I was like, could this be an Addison's type picture? I'm wondering what the potassium is looking like, which could also cause bradycardia.
You might as well go ahead and give them the lab cell, because then I think we're going to have a very interesting discussion.
Yeah, absolutely.
Initial labs, and then what happened over the next 2 days.
So we can absolutely start there. So from a BNP standpoint, sodium was 134, potassium was 4.7, chloride 94, bicarb 23, BUN 43. We already mentioned the creatinine. Glucose is 110. White cell count is 8. Hemoglobin and hematocrit are 14 and 43. Platelets are normal at 199. And I'll give a little bit more, so I'll give the UA. So it's yellow, clear. Specific gravity is 1010. Two plus blood. No nitrites, no leukocyte esterase. Then 3 RBCs per high powered field, 1 WBC, and 2 Highland casts.
Mm-hmm. What was the pH on that?
The pH is 6.
Natasha, that should be 1.010 on the specific gravity.
Mm-hmm.
Okay, Zach, what do you do with that?
so anytime I see 1010 for the spec grav, isostonuria sticks in my head immediately. I worry about his kidney's ability to actually concentrate effectively. 2 plus blood with 3 reds. I mean, I don't know what to really do with that. 1 white cell. Yeah, again, don't know what to do with that. And the 2 Highland casts, does speak to a prerenal cause, but it also doesn't really rule out any other process going on. It could be an evolving process as well that we're really just catching in one spot in time.
That's where we were when he
what
was
is the
admitted.
significance of the hematuria without the without the red cells? I mean, because 3 red,
Yeah.
what is it, up to 5 red blood cells is going to be normal, right? So I mean, it really isn't 3 red blood cells per high powered field, not very remarkable.
Yeah,
But
I
2
mean
plus
that,
blood shouldn't be there, right?
right. I mean that, then my brain goes to, things like that being myoglobin or something like that, kind of mostly giving the positive dipstick. So yeah, Natasha's already writing it, but things like rhabdo, his labs don't really look characteristic for rhabdo. He doesn't have a story that fits with rhabdo at all, but that's typically where my mind goes. And Sal, you might have mentioned this, but no protein or anything on the urine at all.
No protein.
Okay. Okay.
But that's what we had at admission, and it gets much more interesting. Sal, tell them what happens over the next 2 days, and then you have some real meat.
Yeah, and I think this is a lot of the case. So a patient comes in and there's some concern for retention, maybe post-renal injury, but also the patient seems volume depleted and is orthostatic, is given 1 liter in the emergency department and another liter on the floor. So a total of 2 liters of IV fluid of crystalloid, with the idea that if this is pre-renal or post-renal, ideally the kidneys get better. So it was given 2 liters in the first 24 hours of the hospital stay, and the creatinine did not improve. So the trend is 2.4 on admission, up to 2.8 after the first 2 liters of fluid, about 48 hours into the hospital stay. And the patient still has a Foley catheter.
So the Foley. Okay. And any other kind of notable changes on his renal function panel aside from just the creatinine?
So the BUN increased from the 40s to the 60s, and kind of speaking towards electrolytes, the potassium kind of peaked at 4.9. The sodium held steady in the 134 to 135 range.
Joel, could you talk for a minute about hyperkalemia and urinary retention?
Yeah, I mean, so hyperkalemia walks together with urinary retention, and the classic line is that the hyperkalemia is supposed to be out of proportion to the degree of renal insufficiency, right? Because any cause of AKI or decreased kidney function is going to cause potassium to go up, but obstructive uropathy is supposed to cause a particularly acute increase in potassium. And we think it's specific damage to the ENaC channels in the cortical collecting duct, which is going to be the first step for the principal cells to secrete potassium. And so we oftentimes will see pretty wild hyperkalemia and a non-anion gap metabolic acidosis out of proportion to the degree of a renal failure with obstructive uropathy.
Several years ago, a resident came up to me and asked me why this patient had a type 4 RTA, and there was no other good reason. I said, make sure the patient doesn't have obstruction. The patient had bilateral asymptomatic kidney stones. And so that's a real pearl, that if the potassium is high and you don't have a good explanation otherwise, make sure that there's not obstructive uropathy. And there was no reason in that particular patient to suspect it. Yeah.
So the weird thing, and this is kind of just dancing on the head of the pin. It's not classically a type 4 RTA, because in type 4 RTA, they're able to acidify their urine just fine. Principal cells are working fine. It's all their inability to create ammonia. And again, I don't know what's going on here, but he does not have acidic urine at a pH of 6.0. So it does look more like a hyperkalemic variety of a type 1 RTA, which is kind of this, or an electrogenic form of RTA. And I think the nomenclature, there's a little bit of question about whether how people want to refer to it. I like the electrogenic form of a type 1 RTA or a distal RTA, but other people just say, hey, all the hyperkalemic RTAs, we're going to call them all type 4s, which is probably an easier way to handle it. But, I'm not sure. Go on.
The purity of your thought is beautiful.
Yeah, and the when they first discovered this electrogenic RTA, if you read the original articles, the way they would differentiate it from a type 4 is that if you gave supplemental aldosterone, so if you gave fludrocortisone to people with type 4 RTAs, they'd correct, right? You'd be able to, because they're hypoaldo, and this type of RTA, you give them fludrocortisone, doesn't help. That was the test that was done in a short case series in the New England Journal of Medicine, like early 80s.
So what information has Sal not given you that you'd like to know about this increased creatinine? So Zach, you're the resident over on Tinsley, and the intern says, "What the heck should we do, Zach?"
I mean, if something happened like that, I would probably repeat a UA in this guy. I mean, I think there's a lot of utility in trending UAs.
Okay. There's another basic thing that you haven't asked that I'm hoping you'll ask.
I probably won't ask it.
Yeah, and after we tell it to you, you'll never forget it.
Oh, no, very much so.
Maybe Natasha can help you.
Are you thinking about a urine chloride?
We do have some urine electrolytes later on, but there's an even simpler question.
Have we ruled out obstruction like intrarenally? Have we done a renal ultrasound?
Yes. Yeah, we have.
Great question. We had a renal ultrasound and it showed no hydronephrosis.
Yeah. So the
Have you ever
question
get
is,
anything?
Did we ever
like,
grab a CPK to take a look at the rhabdosis question?
CPK was normal.
so the always the question, and what's interesting as an intern resident, you never miss this, but as soon as you get on a Zoom call, you miss it. How much urine is he making? Do you like that question, Joel?
Yeah,
Yeah.
it's like a vital sign.
Yeah. So do you have that written down, Sal?
I don't have the exact urine output. I have some of the urine electrolytes.
So
Can we just get oliguric or non-oliguric? Can we get that sense?
he was oliguric.
He was oliguric.
He was oliguric.
You're giving him 2 liters of saline. He ain't making any urine.
He was making, so I was taught, and tell me if it's changed, Joel, that the definition of oliguria is in a patient like this would be less than 20 cc's per hour or less than 500 cc's per day. And he was making less than 500 cc's per day.
I like 500 cc's per day. The KDIGO defines it as half a cc per kilo per hour.
So Zach, so we're going to get a urinalysis, and what else do you want to get?
I mean, now that we're oliguric, there's utility in getting a FENA and things like that.
Yeah, but Zach, you're grasping at straws. You know as well as I do, and I don't know the answer here, Zach. I'm in the dark also.
Yeah.
But both of us we know that you guys they gave him 2 liters of fluid and his creatinine went up. This ain't going to be pretty. We're not going to get out of this house. This house is on fire. We're not escaping through that door.
No, I agree.
Is there anything else you might do at the bedside? Because we did something else at the bedside.
You look at his IVCs.
We did look at his IVC. So we got all this in the same 12-hour period. So Sal can give you the IVC ultrasound and the repeat urine studies, and then y'all can discuss them. and then we will tie it up in a bow and let Joel make it to his 8 o'clock.
I'm watching my clock. Yeah.
I'm watching mine also because we're not going to let you down, Joel. You're too valuable.
Absolutely. So the bedside ultrasound showed IVC diameter around 1.3 centimeters with a greater than 50% collapsibility with inspiration. Around this
And this is-
time,
Is this after the fluid?
yes, this is on day 3 of hospitalization. So after the 2 liters were given. At that time, orthostatics were repeated, and he still had a 20 point systolic drop with change in positions. So positive orthostatics on day 3. And at that point, a urine sodium was obtained that was 16.
Mhm.
Anything else, Dr. Centaur?
I think we had a urine creatinine also.
Urine creatinine was, and I believe I wrote that down, 206. Excuse me, 203.
So Zach, you wanted it.
Yeah, and I got it. I mean, the urine sodium is low, essentially. I mean, it's less than 20. It's low to me. Did we just get it? Did we not repeat a UA overall? Or
I don't have that written down. Sorry,
that's
Zach.
fine. Yeah.
I got a FENA 0.2%.
Yeah. So, I mean,
So one of the reasons I wanted to present this is when they showed me these numbers, before anybody told me what the fractional excretion of sodium was, I said, wow, his urine plasma creatinine ratio is really high. And
Yeah.
everybody looked at me like, what does that mean? So, and I really wanted Joel to go over that because we actually had discussed this a little bit on Twitter right at that time, Joel.
Yep, I remember.
And-
I do remember that conversation.
Yeah. And so the urine creatinine here gives you just as much information as the urine sodium does. And most people are not aware of that. And Joel, you're comfortable explaining when you see a urine creatinine of 203 with a serum creatinine of 2.8, what does that say to you?
Yeah, I mean, you know, if we can ignore the small amount of creatinine that is that's secreted in the proximal tubule, all the creatinine, 90%, 95% of the creatinine is going to get into the tubules by filtration, and the only way that concentration is going to go up is through fluid removal. And this is 100-to-1 fluid removal. 99% of the fluid is removed to crank that creatinine up from 2 at the beginning of the Bowman space up to 200 at the end of the collecting duct. So this is a kidney that is just scavenging all the fluid back, acting like it is just starved for fluids. Same thing with its very high avidity for sodium, only having a 0.22 sodium atoms per 1,000 filtered being excreted. Just phenomenal sodium avidity in the kidney to retain that sodium also.
So what this said to me, and I'd love for Zach and Natasha, is that there's nothing wrong with his kidneys recognizing his volume status.
mm,
His kidneys are smarter than we are because we can't figure out that he's volume depleted, even after seeing the IVC. And these numbers really help you take what we were scared of is that he had heart failure. And so we were scared to give him too much volume. So now what do you do after you have that? And I think both the IVC and the urine numbers paint you a picture. And so this will also be helpful, especially for you, Zach, So Joel, when you see someone who has true ATN, what kind of urine plasma creatinine ratios do you see?
Oh, urine creatinines of 40, 30 even, so maybe 10 or 15 to 1, not nowhere close to 100 to 1.
Does the physiology make sense, Zach?
Yeah, because it becomes at that point you're recognizing that the GFR is compromised, and there's the ability to filter the creatinine out is impaired. I mean, that makes sense to me.
But it's still the strange thing that urine specific gravity just is weirdly low, right? Because Zach jumped on that right at the beginning. I was in total agreement there that he had this isocynuria. It does not look like a pre-renal state. Is this guy? And we didn't hear anything about a guy being malnourished or having a protein deficient diet. Are you guys holding back on us, or is that wasn't apparent?
If I remember right, the repeat urinalysis had a higher specific gravity.
Mm-hmm.
If I remember it right. So Zach, what do you want to do?
Yeah, I mean, at this point, I'm honestly kind of at a loss. Yeah, I'm gonna have to defer to my more experienced colleague.
No, Zach, you know what you want to do. You want to go with more fluid. I know you know what you want to do.
I mean, everything about it screams that he's being under resuscitated, but I mean, yeah, I mean that would probably be my first, is just give another at least liter and a half maybe and just see what happens.
And his creatinine got better with more fluid.
Yeah,
it did.
So here's the really good question: is how much fluid are you going to give him? And why'd you pick a liter and a half? And how fast are you going to run that liter and a half in? And this is not trivial, because we actually had long discussions about this on rounds, and I was a bully.
So, I mean, he's tolerated the 2 liters of fluid so far. I'm not sure if those were bolused or if that was over, or if those are run at rates, but I'd probably start with giving him that first. I'd probably bolus him a liter and just see what happens. He's in the hospital. If we have to, escalate his care, we can. If he gets, pulmonary edema from that, that's what can happen. But he seemed to have tolerated it okay so far, and he's still making urine, which is encouraging.
Natasha, is that what you would do?
I just came out of the CCU, so fluids make me a little nervous.
Yeah,
Recall
can't do
bias.
fluids there.
I mean, his ejection fraction is not terrible. It doesn't sound like he didn't have any lower extremity edema. I think I'd be okay with. I agree with Zach. Probably bolusing 1 liter, and then probably taking a look at his IVC again, and then reassessing kind of from there.
But about that initial. Oh, I'm sorry, Natasha. I didn't mean to step in.
Oh, sorry. No, I was just gonna say that, with his IVC being so small and his urine, sodium and creatinine, that he can probably use a lot more than 1 liter, at least 2.
Zach, what I was wondering about is he was obstructed when he came in. He had these 500 cc's of retained urine. That urine may not represent his current volume status. That urine may have been older than we think. Mm-hmm. And that initial urine that they got with that initial Foley may have been throwing us off. Mm-hmm. As I'm grasping for straws for a nice explanation. Okay. And Dr. Center even said subsequent urinalysis that were done on that visit showed a higher specific gravity, which would be consistent with that story.
If I remember right. So Joel, this is the constant battle that we have as generalists. And so all residents are generalists. Is the cardiologists don't want us to give too much fluid, and the nephrologists want to make sure we give enough fluid. How do you approach a patient like this? We believe he's volume contracted. He is orthostatic, never has a pulse change. We don't know if that's from carvedilol or did he have some kind of autonomic dysfunction that we were having a hard time finding. But how do you think about when you're doing consults, giving fluid in this situation?
Well, right. the other differential that people are going to throw out is, oh, that low urine sodium, that's from his cardiorenal syndrome that you guys had ignored so far, that this heart failure was driving. That's causing the very low urine sodium. And I think you gotta take in the whole picture and recognize that those are difficult to differentiate, right? The volume depleted state versus the heart failure state. But this guy doesn't have any symptoms of decompensated heart failure, right? I mean, you got to go through the whole thing. He doesn't have peripheral edema. He doesn't have any dyspnea. Doesn't have any orthopnea, right? And then you have the ultrasound. You put it on there, and he's got this small and collapsing IVC. I think here this is a great story where the bedside ultrasound is really helpful. I think this really crystallizes the case. And I think it should give you the confidence to say, hey, cardiology, we're not ignoring you all the time, but for this time we're gonna challenge him with some more fluids.
Sal, tell me if I remember right, but I think what I did is told them to give 250 cc's an hour until the urine output started to increase. But that would be our
or he can't breathe. There's the other possibility. There's two.
Yeah, or he couldn't breathe. Yeah. But I think we even had a BNP that was low.
Nice.
We knew he was not volume overloaded. So Sal, why don't you tell us the resolution of the case, and then we can have some final reflections.
Yeah, absolutely. As Dr. Centaur said, fluid, I believe somewhere between 1 to 1.5 liters were given at 250 from 2.8 to 1.9, and then the day after it was 1.6. So kind of unclear what his true baseline was, but left the hospital with a creatinine of 1.6.
And he was no longer orthostatic.
On discharge, I agree it's a little bit unusual for big carvedilol, one single beta blocker, to cause this degree of orthostasis. It might have been multifactorial, but his carvedilol was temporarily paused until his PCP follow-up and cardiology follow-up.
And we thought he was volume contracted because he was on a standard dose of furosemide. And you see a lot of heart failure patients who are on a loop diuretic regardless of how they're doing. I'm sure you see that all the time, Joel.
Yeah, for sure.
So we're going to finish in 6 minutes, so Joel has plenty of time. Zach, what are your big learning points from this presentation?
Natasha's touched on the big ones there, but the obstructive uropathy with the hyperkalemia associations, one I'll definitely not forget. And another big one is, I still believe in trending UAs. I think it would have been helpful here. At a higher spec grab would have definitely made me think he could take more fluid, and don't trust old urine that's been sitting in the bladder for a while.
Natasha, you've been writing a lot of things down. What's the big point for you?
So I actually didn't know that obstructive uropathy can cause hyperkalemia. Obviously, after talking about it, it makes a lot of sense. And then just reviewing urine, sodium, and creatinine, it's been a minute. And then what Zach is saying about UAs, Dr. Tolani actually gave us a lecture, I think, on Friday on AKIs. And I can't wait to go back to the words and actually use that in patients, because I was on MICU with Zach and he would go spin everyone's urine, and that was really, really helpful. So, you can get a lot of information from urine, and I think it's really underrated, and just emphasizing that.
Joel,
I guess the things that I would like to focus in on is this is a classic case where it would have been so easy to fall into an anchoring bias or a premature closing bias, because you come down and you're told patients get this 80-year-old man with 500 cc's in the urine and an AKI. You're like, okay, you got this, and it's super important just not to rest on that and keep an open mind and not to close the case too early.
Well, we anchored for about 24, 48 hours.
Mm-hmm.
And then my smart intern and resident said, well, but he's not making much urine.
He's not getting better.
Yeah.
Yeah.
So they were really on top of it. The creatinine was going up, and they were the ones who appropriately noticed that the urine output had not increased, and that the patient was oliguric. And then it became the workup of oliguria. That's not from hydronephrosis. And we did all the things to make sure we flushed out the Foley and made sure that the Foley was in the right place. We did the ultrasound of the kidneys. And so we had all that information. And so then they, fortunately, had a really good resident who was good at IV ultrasound. And she went over, and the story all went together. But it was, the reason we wanted to present it is because it's very confusing at the beginning. We're trying to figure out why he has autonomic dysfunction and orthostasis. We didn't want to blame it on volume because his pulse didn't go up. And so that sort of had us confused. And then on the third day, we had a very philosophical discussion about all this stuff.
And I will tell you that I think it is very unusual for if the whole story was pre-renal volume depletion, to give 2 liters and see the creatinine rise. That to me is a wow. Usually it's going to give you a hint. It may not get a lot better. It'll get a little better, but for it to actually go in the opposite direction, that's a real head fake.
Yeah, it was, which is why I wanted to present it because there's nothing esoteric about this case. This is bread and butter ward medicine.
Yep.
But you have to me, the most important lesson is you have to rethink the patient every day. If the patient's not doing what the textbook says he or she should do, you're reading the wrong page in the textbook.
Zach, you handled that nicely. Well done. I got to run, guys. This was a lot of fun. I appreciate the invitation to come. I love coming. Any opportunity to talk with you guys, I would love to take in the future. Thanks, Bob.
Thank you, Bunch. Joel. Sal, why don't you take a last word since you presented this, and what really as you were re-reviewing the case, what really struck you as the real take-home points for those of us who do spend time on the wards?
Absolutely. So first of all, great job, Zach and Natasha and Dr. Top. I echo kind of the type 1 and type 2 thinking, especially it's August, it's early in the year, all of us are promoted, or a lot of us have been promoted to new roles. And I think one key for all trainees and really physicians is to know when to switch from type 1 to type 2 thinking. So it's kind of thinking about older gentlemen, no diagnosis of BPH, comes in retaining urine with the AKI on CKD. Sure, put in a Foley and see what happens in 24 hours. But in patients who aren't getting better with expected therapy, really flip the switch and begin thinking systematically about pre-renal, post-renal, intrinsic renal forms of AKI and going from there.
Great. Thanks everybody who tuned in and listened to us work through this case. And I have to say great things about the team that Sal picked up from me that took care of this patient.
Thanks, everybody.